our reason for being
It's what we train to do.
is to do things to
Yes.
help people. Like we exist to bring it to our patients. It meaning like we're going to deliver every ounce of our skill set and energy to try to help somebody.
Right.
Now, we're not going to twist anybody's arm ever to do anything. So I think that's where, I mean, I'd say like that doesn't happen here, and it never will as long as I'm, a part of this thing. Is that like that's not what we're about. So, but on the flip side, I'd say, absolutely. We were talking earlier about like there's a philosophy or opinion in medicine, and the care that you seek is going to be coming with a specific philosophy or opinion. Now, in the typical medical environment, in Milwaukee, which is where we're sitting right now, the medical environment is dominated by big box healthcare, big systems with thousands of doctors, and they've got a certain viewpoint. And their viewpoint is, they can speak about it, I'm not going to, their viewpoint is really more about, how do you say this, broad, they can do lots of, they can treat a lot of different conditions, and they can do that in a adequate manner. None of these systems can do what we do, and part of that is because get back to that point, is a part of the reason we exist is to do what needs to be done, and that's period. And then the next sentence is, the reality is the things that we do on a hourly basis are things that these big systems cannot do. They've outlawed them from being done. Not because of medical reasons. They outlawed them from being done because it doesn't fit their model. Their model, if you go to a big box healthcare system, then their model is about keeping you coming back, Band-Aid after Band-Aid. That's good. Like, that's great for them. Alternatively, if you need something, well, we got to take you to the operating room to do it, because we have they've got hundreds of operating rooms that need to stay filled. They've got anesthesiologists and OR crews that need to be working. It doesn't work for them to do office procedures, and therefore they do not allow their ENT doctors to do them. That's truth. And then the additional truth is, they don't care about ENT. I mean, their ENT docs care about ENTs, and their ENT docs care about ENT issues. Their ENT docs are certainly highly trained and are experts in the field. The challenge is those ENT docs have basically, by necessity, they need to be neutered to be part of that system.
Handcuffed. Yes.
Yes, handcuffed is maybe a better word for it. But because if you want to play in that system,
because there are male and female ENT docs.
Neutered is a gender neutral term.
Is it? Okay.
I don't know.
We won't go there, but yes.
But
handcuffed.
You have to play by the rules of the system that
Yes.
you're in. In our system, so we have a system, we have a worldview, we have a mindset. There's how we do things, and how we do things is entirely our. The sun in our solar system is the nose and the throat. Like, that's everything we're about revolves around that. There's nothing more important to us than those areas, versus in a big box healthcare system. If the nose and throat issues are like in some other galaxy far away that nobody cares about, because it's so low on the totem pole of things that they care about, versus the big ticket items that they really want to fill their beds up with.
But those nose and throat items account for a phenomenal amount of cost of healthcare.
Sure.
And lost productivity.
And misery, and it's important stuff, and it's paramount. Like, somebody's got to take this stuff seriously, and we do take it seriously. I mean, and that's out of necessity. It needs to be.
Let me ask you, what percent of surgical procedures that are done do you think are elective versus emergent?
In all of healthcare?
Yeah.
Oh, I'd say 99% of healthcare is elective procedures.
Right. And I totally agree. And what we do here are elective procedures. Right. And so, so I feel like, if we do a lot of procedures here electively because patients want them done. And like you said, we go through different options. I've never told a patient, you need to have this done.
Right.
Like, I've never said that. Since
but you do offer guarantees, right?
I never offer guarantees either, right?
So that's because you can't, because you're human, right?
Yes.
As am I. And
Right.
so the wonderful thing in medicine is that you cannot be all knowing. You cannot be you are not. And you could do the best procedure in the world, and there's still a percentage of the time that you're
Right.
not going to get the outcome you're looking for.
Well, and it feels crummy, you know, and I think that's the bar, you know, like one of the worst things in medicine is doing something on a patient and them not having the outcome that you guys hope that they would have. Like, that sucks.
But it happens.
It happens.
It happens. It sucks. It happens.
Yes.
There will never be a world, never, even when robots are doing our job, there'll never be a world where that doesn't happen.
Right. But I think that also that helps us set a bar for, okay, when we decide that we want to bring in some sort of procedure into our office, and let's say it's an office-based procedure, that's why the threshold for, is this going to work for our patients, is it has to show at least some quality of outcome, right? Mm-hmm. That's why we're not going to do something that's 50-50, because that just doesn't work in our model. Like, that doesn't make any sense, right? So the balloon sinuplasty, the turbinate reduction, and other things that we do, it has a high threshold for success, right? Otherwise, we wouldn't bring it here and we wouldn't do it.
Yep, correct, absolutely.
Like, so because one, we don't want to have to then turn around and talk to a patient who didn't have a good outcome and have that be a consistent thing. Like, fortunately, it doesn't happen often, you know, wonderful, but it still happens. We're not 100%,
Sure.
but like you said, we're human.
Yeah.
You know? And to human is to err.
Right.
At times.
Yeah, which is like either you deny that or you sort of embrace that. And the nice thing is, yeah, for procedures that we do, the likelihood for success is really high.
Right.
Now that's huge asterisks. It depends on each particular individual's their issues. There's other factors that come into play.
Yeah, what they're trying to achieve and their goals.
Like, I mean, when as we're doing procedures, we see folks back on the back end, and it's a very rewarding. This is a very rewarding place to practice medicine. And in fact, for the docs and the PAs and folks who practice medicine elsewhere, to a man and woman, it feels like this is as good as you get that way. And not because they're drinking any special Kool-Aid, it's because the patterns and pathways and how we take care of patients, it's not 100% successful, but when we strike out, swinging. We strike out. We put every single patient we're taking care of, we're going to bring as much of our force into getting you better as exists. And even then, yeah, sometimes sometimes that's still not good enough, but it won't be for lack of trying. And I think the reality, I know the reality, unfortunately, is because we see many patients, hundreds, thousands of patients who've been treated elsewhere come to see us for second opinions or third opinions, or maybe they've had procedures done elsewhere. And the unfortunate truth is, I'd say, I don't find that same mindset, elsewhere. Not to knock anybody else, because certainly, we are not without sin. We are not without our own issues that way. But I'd say, I see a lot of, I guess, when I see folks who've been treated elsewhere, I see a lot of folks who sort of had issues with things being, they came into those other places with anatomy with its tooth shut down, have procedures that didn't get the anatomy open to begin with, and therefore they're still suffering. That's the common thread.
And the patient in their mind feels like, oh, I had this procedure done and it didn't work for me. Whereas I think that the nuance around that is, you could have had a procedure done. If it's not done to the full extent that it could be done, then maybe it didn't work for you.
Sure.
Right? And so, but a person doesn't understand that outside of medicine. Like, hey, if I had my ACL repaired and it didn't work or it failed, and there's a lot that goes into that, and it's no different with the nose and what we see, and that's why, hey, we can get a scan in the office. We can look at the entire blueprint of what's going on and get a good assessment about what's going on.
Yeah, so like, for example, the goal of sinus surgery is to open the sinuses so they can drain properly. Just because you've had sinus surgery doesn't mean that your sinuses are open.
Correct.
Unfortunately.
Correct.
Sometimes things were open and they shut back down, and sometimes things weren't ever truly open. that way. That's one example of that. But there are other examples of the same sort of thing where it's sort of, and even there, on sinus surgery specifically, there's older techniques and then newer techniques, and there's just a wide variance in what that means. And even when we look at this, we talk about this all the time, when we look at studies, like we read the literature, you're looking at these studies, and what I just said is, just because you've had sinus surgery, it's not apples to apples. So when you look at studies for success rates after sinus surgery,
you don't know what was
you
done.
don't know what's. I don't know, because yes, you had surgery done, a procedure done, but did it get you where you needed to be? And and it's challenging. And so anyway, I mean, I think it's. Again, there's some things that people sort of assume, like out of the gate. Like we were talking about medications and things like that before, but I'd say on this front, I'd say, yeah, just because you had a septoplasty doesn't mean your septum's straight. Just because you had sinus surgery doesn't mean the sinuses are open. Just because you had a turbinate reduction doesn't mean your turbinates, have been adequately reduced. All those things, and on and on and on and on. Now, maybe so. Maybe you had sinus surgery, everything's open, and you're still having issues. Mm-hmm. Okay, that happens. Maybe you had a septoplasty, your septum's now straight, and you're still having issues, fine. But I think that's where part of our job is to assess, and we need to understand what's going on, then we need to explain what's going on, and then we need to explain, what the options are. And almost always, there's almost always some option, that we can think through. It may not be a procedure, maybe something medication-wise, it may be a combination of things we could do, but there's almost always something that can be done. And that's for, that's for the folks who've sort of swung and missed and just aren't where they need to be. The good news is that for most folks, especially for folks who've never had anything done procedurally, is that success rates there are high, really high.
Right. Even people with a revision, because again, sometimes it's maybe even a small thing that we can address, or if it's a turbinate issue and those turbinates have just gotten swollen again, we can be a little more aggressive, get them reduced. Like that could be a huge win for people that have even had procedures before. But that's the advantage of having imaging accessible, is that we can really understand what's going on, and we can say, okay, this is the whole picture. We can look in your nose, we can see a picture with a CT scan, and come up with a plan. And I think that, as you alluded to previous, that okay, so we're ENT docs, right? Which means we have an additional skill set that all ENTs have the ability to bring to the table. So like, we can treat with medications, we can treat your sleep apnea issues with CPAP or whatever else, and we can look at those things. But we also have this ability to level up, whereas other providers out there, allergists and primary care docs and maybe sleep medicine neurologists, and I'm not knocking anybody, they all have their kind of specialty, but we just bring an additional, I think, skill set to the table that we can apply if needed.
Right. Yeah, no, I agree. I mean, and that's what we do.